All right, so excited to welcome everyone to Grand Rounds this morning for a really special presentation. Today I have the distinct pleasure of introducing Dr. Emily Owen as our Grand Rounds speaker. Dr. Owen completed her undergraduate degree in biology at the University of Portland before completing her MD training at the University of Washington School of Medicine. As you all know, Emily completed her internal medicine residency training here at UW before continuing on this year as the primary care chief resident. Emily has distinguished herself as an exceptional leader, educator, and advocate this year as chief resident, while continuing her clinical practice at Union Corners. She's been an outstanding role model and mentor to our primary care and categorical residents this year and throughout her training. Emily has won numerous awards for her service and scholarship, most recently the Lawrence G. Crocker Award for her commitment to and excellence in general internal medicine. Dr. Owen will be leaving UW next month to start as an attending physician at the Community Hospital of Anaconda in Southwest Montana, and she'll be speaking today about addressing rural healthcare disparities through resident education. Please join me in welcoming Dr. Owen.
Great. Thank you so much, Andy, for that kind introduction. Again, it's truly a pleasure to be here. Let's get started. First off, I have no disclosures. So let's first take a pause. And I wanted to share a few facts with you all. So did you know that people who live in rural areas have a 30% increased risk for stroke mortality compared to urban dwellers? Or did you know that women in rural areas suffer higher rates of pregnancy-related mortality compared to urban dwelling women? And of those women, 10% must drive over 100 miles to receive any sort of routine perinatal care. These are just a few of the startling statistics regarding rural health disparities. I know for me personally, hearing these numbers trouble me. And I feel it's safe to speak for the crowd that as healthcare professionals, when we hear of such disparities, we are driven to find solutions. Today, I'd like to highlight existing rural health disparities, as well as spark discussion, ideas, and bring forth some solutions to help close the gap between rural and urban health outcomes. So to take a look at my learning objectives today, so I hope at the end of this talk, you'll be able to describe the changing demographics of rural America, identify key health disparities between urban and rural communities, outline current successful recruitment strategies for rural physicians, and then lastly, be able to discuss the efforts being made to expand rural graduate medical education for GME opportunities across the state. And so an outline for today's talk includes defining key definitions and demographics. Then we'll move on to looking at specific rural health disparities, followed by physician shortages. Next, we'll discuss current recruitment strategies for rural physicians. And then lastly, we'll end on current as well as future directions for rural GME in the state of Wisconsin. So starting off, when I say rural, what do you think of? As you can imagine, people's definition of rural really varies based off of where they grew up and where they're currently living. A few towns I want to highlight include Phillips, Wisconsin, pictured here. So my husband and I drove through this town last summer on a camping trip. It's a town of 1,500 located north in Price County. I would say this town feels like everyone knows everybody. There's that yellow lab that patiently sits outside at the local breakfast spot. Some would say, yes, this is rural. But then the question is, anything larger than, say, Phillips, Wisconsin, is that considered urban? This is compared to my hometown, which is pictured below. So this is Bremerton, Washington. So this town has a population of 40,000 people. Some would say the fact that there is no Target or Trader Joe's within city limits, that maybe this town is rural. So again, as what you can see what I'm hinting at, is there's not a clear definition of rural, and really there's no one universal definition. And definitions across the country and various programs can be based on either population or geographic boundaries. I want to highlight though that defining rural and finding a good definition, it truly matters. Because defining rural is important as it guides policymaking, funding, and how we make sure resources are allocated to the appropriate communities. So I want to highlight two popular definitions, and these are definitions that we often see in mainstream media as well as often in medical literature. So the two definitions are from the federal government, the US Census Bureau, as well as the Office of Management and Budget definition. So taking a deeper look at the US Census Bureau definition. So the US Census Bureau does a great job of defining rural by really not defining rural. So the definition includes rural, includes all people, housing, and territory not within an urban area. So now you're probably wondering, well, what's an urban area? And so an urban area has two groups. So either there's an urban area, which consists of greater than 50,000 people in that core area, versus an urban cluster, which still falls within the urban area category. And so this would be 2,500 to 50,000 people. So then roughly, rural, based off of the US Census Bureau definition, would be any community or area that has less than 2,500 people. The US Census Bureau definition can be challenging because it really goes off of population and does not really follow any city or county boundaries. This is in contrast to the Office of Management and Budget definition, or the OMB as I will refer to it as. So the OMB does rely on counties to define urban versus rural. So it takes a look at urban counties, considers them metropolitan areas. And so these metropolitan areas or counties have greater than 50,000 people in the core urban area. And then it considers rural or non-metropolitan areas having core urban areas less than 50,000 people. So I want to highlight this map of the state of Wisconsin pictured below. And so the state of Wisconsin is then divided up into the various counties. As you can see, the yellow counties are urban counties, and to no surprise, more south central Wisconsin is lighting up as yellow, including Dane County, demonstrating that it is an urban county. And then to no surprise, as we go further up north, we're seeing more green counties, which would be consistent with rural counties based off of the OMB's definition. Next, I want to highlight this map. So I feel like this map does a nice job of where it actually takes the OMB definition as well as the US Census Bureau definition and overlaps the two. And so as you can see, there's many areas in the state of Wisconsin where the two definitions agree. So the purple is indicating the OMB's definition, which would be purple would indicate an urban area or metropolitan county. And then the brown and orange are indicating urban areas based off of the US Census Bureau definition. So as you can see, Madison is lighting up as orange, indicating an urban area, same with Milwaukee. And then they're falling within the purple, which would be consistent with an urban county. But a few towns I want to highlight, and again, come as a surprise to me. First town where the star is landing on is Mount Horeb. So for me personally, I love visiting Mount Horeb, taking a little weekend trip out there, walking in the downtown area. And certainly when I'm out there, it feels quite rural. But actually, what I want to highlight is based off of the OMB definition, as well as the US Census Bureau, Mount Horeb is considered an urban area. The next town I want to highlight, this next star, is New Glarus. So also New Glarus is another cute little quaint town that I love to walk down through. So New Glarus I wanted to highlight it because it's where the two definitions actually don't agree. So based off of the US Census Bureau definition, New Glarus is considered a rural community or a rural area. But based off of the OMB's definition, it would consider New Glarus to be in an urban environment or a metropolitan county. So overall, what I want to highlight is that the OMB has a tendency to undercount people in rural areas, while the US Census Bureau has a tendency to overcount people living in rural areas. So after reviewing some of the most commonly referenced definitions for rural areas, let's look nationally. how many people are truly living in rural areas across the country? So utilizing 2010 US Census data, rural America consists of 60 million people, which is roughly 19% of the US population. So next, I want to take a pause and have you think about, who do you think lives in rural America? Who are the individuals living in rural Wisconsin? For me, I picture this man. I would describe him as an older gentleman, identifies as white, possibly of Northern European descent. And this image isn't too far off based off of the Wisconsin 2020 US Census data. So based off of our current census data, 80% of the state of Wisconsin identifies as white or Caucasian. But what I want to highlight next is that rural America is changing. First off, what we're seeing in rural America is that it's aging. So this map below is showing percentage of population of individuals age 65 and over based off of 2010 census. So this is the map on the left. And then the map on the right is looking at percentages of population in age 65 or over for projections into 2040. The lighter tones, the light pinks, are indicating that less than 20% of that county is age 65 and older, while the deeper reds are indicating that greater than 35% of that county has individuals who are over the age of 65. So as you can see, the state of Wisconsin on the left is predominantly the lighter pinks, beiges, again, indicating that a lot of the counties have less than 25% of their residents who are over the age of 65. Now, this is in contrast to the map on the right, which is showing that, again, for projections in 2040, we are going to see many more people age, and predominantly in northern Wisconsin, where there are many rural counties. We're going to have, in many counties, where greater than 35% of those individuals are over the age of 65. And so as you can imagine, with this projection that rural America will continue to age, there's certainly a concern. And as we see in our clinics, unfortunately, with age does often come additional comorbidities and need to seek medical care. So certainly there's a concern. Is our healthcare system ready to handle this increase in aging individuals? And so next, what I want to highlight is not only is rural America changing based off of age, but also we're seeing consistent growth for certain ethnic and racial minorities. So up below is a graph demonstrating whether or not there is population growth, which would be then positive change, or population loss, which would be negative change. And this is data from 2012 looking up until 2017. And so as you can see, two particular populations are experiencing growth in rural America or non-metropolitan areas. And that's the American Indian and Alaska Native population, as well as the Hispanic and Latino population. We're seeing consistent growth in rural communities for those racial and ethnic minorities. And I do want to highlight that historically, non-Hispanic Blacks have represented the largest minority population in rural communities across the country. However, by the 2010 census, we were then seeing that the majority of, or the largest minority group in US has now shifted to the Hispanic and Latino population. So taking a look specifically at, again, our racial minority ethnic makeup within the state of Wisconsin specifically, I took a look at Wisconsin 2020 census data. And so what I found statewide, there was a 33% rise in individuals identifying as Hispanic, Latino, or Spanish across the state of Wisconsin. Then looking at specific counties and looking at which counties had the greatest growth, I found it interesting that Trompealeau County as well as Pepin County had the greatest population growth for the Hispanic and Latino community. And so my next question is, well, where are those counties? And so pictured below, circled are the two counties, Trompealeau and Pepin, are the dark purple in that circle. And so both of these counties are actually considered rural counties. And what this map is showing, again, the dark purple would be indicating greater than 100% or more change in the Hispanic or Latino population in that community. And the lighter purples would be indicating, again, less of a change, going down to 0 to 25%. So what I found interesting, and I think some of the shift in demographics may be explained by the changing demographics of our dairy workforce, actually. At the moment, it's estimated that roughly 40% of Wisconsin's dairy workforce is made up of migrant farm workers. In the early 2000s, the estimates were at roughly 5%. As you can imagine, many dairies as well as farms are located in rural communities. And this shift in the dairy workforce may help explain some of the shifting demographics in our rural communities. So again, I've already hinted at it, but I want to ask you all the question, do you think and are we meeting the healthcare needs of rural communities? And then my follow-up question is, are we prepared to meet the future needs for our rural communities as demographics continue to shift, including aging adults and changing racial and ethnic makeup of our rural areas? Unfortunately, as you might suspect, the short answer to this question is no. So let's take a deeper look at the current and existing rural health disparities. So I've already highlighted a few at the beginning of my talk. But additional rural health disparities I want to highlight include rural residents compared to urban residents experience higher rates in all-cause mortality, this is across the country, tobacco use, obesity rates, diabetes prevalence, and then excess or preventable deaths from the 5 leading causes of death, which include heart disease, stroke, unintentional injury, which this includes unintentional poisonings, overdose, and motor vehicle accidents, cancer, and chronic lower respiratory diseases. So I want to highlight these rural health disparities, again, are across the country. All racial and ethnic groups are included. But unfortunately, when we look at particular ethnic and racial minorities in rural areas, unfortunately, some of these populations are experiencing even greater health disparities. And I want to include some of the following. So for rural non-Hispanic Blacks and American Indian Alaska Native adults, they are more likely to report having multiple chronic health conditions compared to non-Hispanic whites. Additionally, adult rural non-Hispanic Blacks were more likely and more at risk for obesity as well as severe obesity. And then lastly, American Indian and Alaska Native population are twice as likely to report late or absolutely no perinatal care during pregnancy. And then next, I want to follow up looking a little more deeper at this topic of excess or potentially preventable deaths. And so this graph is taken from in the CDC's Morbidity and Mortality Weekly Report. This is back in 2019. The CDC reported on rates of preventable deaths compared to urban versus rural areas. And so what I mean, and what the CDC means by potentially excess or preventable deaths, they defined these deaths for individuals who were under the age of 80, and these deaths exceeded the numbers that would be expected if the death rates were of the states with the lowest rates. So again, the CDC identified benchmark states across the country with the lowest rates of these types of deaths, and then compared urban versus rural areas. And as you can see, across all 5 leading causes of deaths, the percent of preventable deaths or excess deaths were greater in rural versus urban area. Again, on this graph, the dark brown is indicating non-metropolitan or rural areas compared to the lighter brown is consistent with urban or metropolitan areas. So why do these disparities exist? As you can imagine, there's not one easy answer, and there's many factors that contribute to these ongoing rural health disparities. A few I want to highlight, or again, are theorize that are contributing to the rural health disparities include education. So post-secondary education rates are lower in rural communities compared to urban. Overall household incomes on average are lower in rural versus urban areas. And then next, I want to highlight access to medical care, which includes insurance coverage. So overall, the rates of the uninsured who are less than 65 are higher in rural areas compared to urban. Distances to hospitals and geographic isolation for some of these individuals. So unfortunately, the distance to medical care has often gotten worse for many rural communities. As we look over the last 10 years, we've seen over 130 rural hospitals close. So unfortunately for some individuals, their drive to the hospital and drive to medical care has only gotten greater. Next, access to primary care physician. Are there primary care physicians available in that community for that rural resident? Oftentimes the answer is no. And then lastly, access to subspecialty care. When they need to see cardiology, gastroenterology, are they able to get subspecialty care in a timely manner? And does that contribute to these ongoing rural health disparities? So next, what I want to highlight and take a deeper look at is access to primary care physicians and how this might contribute to the ongoing rural health disparities. So let's look at physician shortages across the country. So again, I highlighted earlier in my talk, at the moment, roughly 20% of all residents live in rural areas. Despite that number, only 9 physicians practice in rural areas across the country. And so unfortunately, this results in 77% of rural counties are designated as primary care health professional shortage areas, which for short, we call these HIPSAs. So again, this is indicating that the majority of the rural counties across the country are struggling to have routine access to primary care. And so I want to highlight, just as rural America is changing, also the rural physician workforce is changing. Unfortunately, the rural physician workforce is also not immune to aging. And so this table, is looking at rural versus urban physicians who are under the age of 50 and whether or not, again, they're joining a rural versus urban practice. And so what we've seen, looking from 2000 to 2017, we've seen a 25% decline in physicians who are under the age of 50 joining rural practices. This is in contrast to urban areas that's actually seen a 12% gain in physicians who are under the age of 50 in the last 17 years, again, from 2000 to 2017. And so overall, looking across the country at the moment, physicians age 60 and older make up 25% of the rural physician workforce. And this is compared to 18% in rural areas. So again, you can see in the next 5-10 years, the projection is that we'll have many physicians retiring who are predominantly in rural areas. So the concern is that these existing physician shortages are projected to only widen as more physicians retire in these rural areas. So certainly we like to think that adding more primary care physicians to a community could actually change these rural health outcomes, but do we have data to actually support that? So what I want to highlight is this study that was published actually back in 2005. But what I found is that this study kept being frequently cited and referenced in more recent literature surrounding rural health disparities and physician shortages. So I took a look at this paper, again, published in 2005, and it evaluated rural and health outcomes and the factors that may contribute, including availability of primary care physicians, as well as how income impacts these rural health disparities, as well as education. So the study looked at over 3,000 counties across the US. And actually they were able to then capture 99% of US counties. They then divided the US counties into either a metropolitan statistical area or an urban county compared to a non-metropolitan statistical area or a rural county. All counties were then classified as either being below or above the national 75th percentile in terms of primary care physicians per 10,000 people. The study then evaluated the effects on all-cause mortality, heart disease mortality, as well as cancer mortality. So other covariates, when they were looking at primary care physicians specifically, covariates including education, income, unemployment were then controlled for. So taking a look at the results. So what I want to highlight is the bottom row. And so when looking at rural counties that were in the top 25th percentile for number of primary care physicians per 10,000 people, what we saw is all-cause mortality and heart disease rates all improved compared to the counties who were below the 75th percentile. And these differences were considered to be statistically significant. I do want to highlight that also all cancer mortality did improve, but to a lesser degree. So again, to summarize, non-MSA counties or rural counties with primary care physicians in the top 25th percentile across the country had improved rates in all of the following: again, all-cause, heart disease, and cancer mortality, but to a lesser degree. What I found was interesting, though, about this study is that we didn't see this effect in urban counties. So again, whether or not the urban counties were in the top 25th percentile or in below 75th percentile, there was no difference as far as all-cause, heart disease, or cancer mortality. And so why wasn't it true? Why didn't primary care physicians make as much of an effect in these urban counties? And so the study tried to address this. I thought they brought up some valuable points. So that included that increasing supply of primary care physicians can only help to a certain point. And then other interventions are needed, including other avenues such as having nurse case coordinators, care coordinators present in that community, social work, and then other key players of the healthcare team that help facilitate patient care. So again, as we all know, physicians are just one piece to this puzzle, and we need other key players to help improve these health outcomes. And then lastly, they highlighted that the positive effects of primary care are often greatest in areas with the greatest risk factors. And so many of these rural counties across the country had some of the lowest numbers of primary care physicians. And this was compared to urban areas where the degree of shortages were overall less. So again, many of these rural counties were at greatest risk, and by only adding, say, a few additional primary care physicians, some great benefits could be seen. So next, we've talked about physician shortages and how limited access to primary care physicians can contribute to rural health disparities, or again, that there may be an association. So looking at, if we want to attack physician shortages, what can be done to resolve physician shortages in rural areas? And so first, we need to understand the predictors. Why are physicians choosing to practice in rural areas? What brings them to rural communities? So really, one of the top predictors for why individuals practice in rural medicine is if they grew up in a rural community. And I want to highlight that, again, despite 20% of our US population living in rural areas, currently less than 4% of medical students come from a rural area. Some other contributing factors I want to highlight. Individuals who had a strong clinical experience in rural areas during their medical school or residency, this experience did have an impact as to whether or not they chose to practice in a rural versus urban area. Next, I want to highlight employment opportunities for the spouse or partner. So certainly in the last several decades, we've seen a shift of now 2 people are working in a household. And so particularly in rural communities, as you can imagine, employment for other jobs outside of, say, a healthcare system can be challenging. And so this could be a limiting factor for why physicians choose not to practice in a rural area. And then lastly, primary care focused specialties are a predictor and is a reason why people go to rural practice. As you can imagine, across the country, family medicine is by far the most common specialty that's practicing in rural areas. And just there's the reality of if you choose a specialty of, say, interventional radiology, you're just not going to be able to practice in a small rural community because you need access to tertiary care centers, you need access to large numbers of patients in volume. So now that we know some of the predictors for why individuals choose rural medicine, let's look at some current recruitment strategies. So I want to highlight that programs and universities across the country have gotten quite creative with how they recruit physicians to rural areas. So first, I want to highlight institutions across the country are actually focused on rural high schools and hosting medical career events. So I want to highlight Oregon Health Sciences University, based out of Portland, Oregon, has a program where they're hosting career days for rural high schools across the state, again, in hopes of attracting these students to ultimately pursue careers in medicine. Next, granting undergraduates from rural areas early acceptance into medical school. So the University of Kansas recruits undergraduates from rural areas who have a high likelihood of then returning to rural areas. These selected students participate in a unique curriculum during undergraduate and then are guaranteed a spot in medical school. Rural training tracks within medical school. So I myself participated in a rural training track at the University of Washington. I want to highlight our excellent program here at the University of Wisconsin, the WARM program. So the WARM program is a separate application process for individuals who are applying to medical school and who are interested in rural medicine. WARM curriculum provides unique skill sets that then prepare these medical students to ultimately be successful in rural communities. Roughly 50% of WARM graduates are practicing in rural areas. And this is compared to roughly 10% of graduates who complete kind of the traditional track at the University of Wisconsin, then go on to practice rural medicine. So certainly the WARM program has seen some success in recruiting medical students to then practicing in rural areas. Next, I want to highlight rural training opportunities and residency. So family medicine certainly leads the way as far as having the most rural training programs and opportunities across the country. Looking at all the family medicine rural training tracks across the country, for individuals who participate in these tracks, approximately 35% then ultimately practice in rural areas. And this is compared to roughly 17% of family medicine physicians who participate in a more traditional or non-rural track experience. And then lastly, financial incentives. Certainly hospitals and employers, as well as state and federal programs, have gotten a little more creative as far as trying to give some financial incentives for why individuals should choose rural practice. Particularly, I want to highlight the various loan programs that are offered. Again, whether it's the employer, or even the state of Wisconsin offers various loan repayment programs to again entice individuals to practice in rural areas. But what I want to highlight next is looking a little deeper at rural training opportunities specifically for residents and during residency. So I'd like to highlight this paper. So this is a paper published in the Academic Emergency Medicine Journal. What it consisted of is actually a survey where 111 emergency medicine program directors were surveyed across the country. The PDs were asked to report on whether their program had a required rural rotation or whether they had an elective with a designated rural site, Or the resident could say participate in a rural rotation, but they had to kind of figure out the logistics and identify that site. The survey then asked the program directors to report on where their graduates were for a whole 2 years, so 2 classes of residents. They then wanted the PDs to report on where they were practicing emergency medicine upon graduation. So taking a look at the results of this survey. So on the left, we see the type of rural rotation. So the rotation type, again, was either it was required, and so only 5% of the responding emergency medicine programs actually had a required rural rotation. This is then in compared to there could be an elective pre-designated site that was in a rural location, or an elective and no pre-designated site. So again, the individual had to find their own site and create their own rotation. And so what the survey found is that for participants participating in a required rural rotation, roughly then 22% of those individuals were practicing in a rural location upon graduation. This is in comparison to, say, the individuals who participated in a program where they had an elective, but there was no pre-designated site. Only 6% of those participants were then practicing in rural medicine. So this data from the surveys demonstrates that exposure to rural EM rotations through a required rotation has a positive association with residents then choosing rural practice. And also, I think this survey highlights the importance of having a designated and established rural rotation compared to, say, offering an elective rotation, but the resident then kind of has to figure out and seek out that opportunity. So again, I've highlighted that rural experiences in medical school and residency can have an impact on whether or not a physician chooses rural practice. And I've also highlighted the fact, again, specifically looking at rural GME, that if we expose residents to required rural rotations, again, that further increases their likelihood of practicing in rural areas. So the next question I want to ask you all is, what is being done to expand rural GME opportunities? And I want to take a deeper dive both federally and at the state and locally of what is being done to, again, give residents more opportunities to rural rotations. So looking at the federal level, I want to highlight the Consolidations Appropriation Act of 2021. So this legislation most notably created 1,000 new residency slots across the country. And these slots will be distributed over a 5-year period. But also the legislation amended the Medicare GME Rural Training Tracks program. Some things I want to highlight include that the Act now allows for FTE cap adjustments that are available when urban programs add new rural sites. Previously, FTE cap adjustments were only available when an urban program added their very first rural site. Overall, these changes allow for greater flexibility and financial feasibility to create rural training experiences for residents. Next, let's take a look at the state level. So I'm very proud to say that Wisconsin has some incredible programs at the state level who are really dedicated and driven to expand rural GME across the state. And certainly, as living in Wisconsin, we should be invested in rural healthcare because based off of our census data, 25% of Wisconsin residents live in rural areas. And so we are, as a state, above the national average for number of people living in rural areas. So a few programs I want to highlight is the Wisconsin Rural Physician Residency Assistance Program, also known as RIPRAP, established in the UW Department of Family Medicine and Community Health. And this program provides grant funding for rural training program development across the state. I also want to highlight the Wisconsin Collaborative for Rural GME, also known as the WCRGME for short. It aids in the development of rural GME training opportunities as well across the state. And then lastly, the Wisconsin Department of Health Services also provides various grants for residency programs and hospitals who are interested in expanding their rural training opportunities. So taking a look at the state level, again, as I highlight, I'm proud to be practicing in Wisconsin. We're really making changes to expand our rural GME footprint. So we've seen ongoing growth in rural GME opportunities. So information put out by the WCR GME reports that from 2012 to 2021, we've seen statewide, we went from 2 rural training programs for all specialties to now we have 12 rural training programs across the state. And so some of these rural training programs in Wisconsin include UW, which has several, which I will just highlight shortly. MCW also has several rural training programs. Monroe Health Partners, which is located in rural Western Wisconsin, it's a family medicine program. And then Augusta Family Medicine Rural Training Site. So looking specifically at UW, again, UW has done some great work to expand their rural footprint. So looking at the family medicine department specifically, we have the rural health equity track that they offer, which is a post-match track opportunity for family medicine residents. We also have the rural training track in Baraboo, which is actually a separate match process for family medicine residents. And then our OB-GYN department was actually the first in the country to offer a separate match for an OB-GYN resident who's dedicated in following a rural track experience. And then our psychiatry department offers a public health track, which allows individuals to rotate in more rural community practices across the country. And then lastly, our general surgery department offers a separate match for a dedicated rural general surgeon. So as you can see, I did not mention internal medicine in that previous list. And what I want to highlight is that nationally and locally, far fewer opportunities exist. And I do want to highlight that I think understandably, it's somewhat because of the nature of our specialty. So within internal medicine, as you all know, there are many subspecialties, and often, again, many residents are subspecializing. And so I realize that the pool of rural general internists is quite small. And certainly for individuals who are subspecializing, again, there's more of the need and draw to be near a large academic center, tertiary care center, with access to many patients in large numbers. So overall, I realize, and I think this will continue to be true, that the internal medicine rural training experiences are just less of a demand compared to, say, family medicine. But what I do want to highlight, again, locally, as far as what we offer our residents at within our internal medicine program, is that currently residents do have the opportunity to rotate it at UW Health's Beaver Dam Clinic. And again, this is a great 1-month opportunity for residents to rotate outside of Madison and get a taste of what a smaller community might feel like. But currently there is no dedicated rural track within UW internal medicine residency. So taking a look further, again, nationally, there are far fewer internal medicine rural tracks. And so I went on a search to find various programs across the country who do offer a rural IM track and what it might look like, and what would it look like if we were to say, bring a rural track to the internal medicine residency program. And so I want to highlight Maine Medical Center in Portland, Maine. So they offer a rural internal medicine track. So this is actually a separate track where they're matching a resident per year. The resident who's matched into this track would then share their time between Portland, Maine, as well as Norway, Maine. And so Norway, Maine is roughly 45 miles outside of Portland. The Maine Medical Center and the Maine Medical Residency does offer an X+Y structure, which is what we will be transitioning to this summer. And so this structure does allow for that rural track residents to have regular blocks of time where they're out spending prolonged chunks of time in that rural community. And so next I want to highlight is actually an example of a rural internal medicine track resident at Maine Medical Center and what their schedule looks like starting from PGY 1 year to PGY 3. And as you can see, there's a significant change in their schedule. So it's divided between their time in rural Norway, Maine, as well as then they're spending time at the urban Portland, Maine medical campus. I want to highlight a few key things that I particularly like about this schedule and what I think would be important if we were to bring a rural track to our program. So at Maine Medical Center, the continuity clinic for this rural resident is located at the rural site. And I think that's really important, as the resident then gets the benefit of truly building a patient panel in a rural area and really feeling connected to that community. I also think it's important because that resident will then get used to the fact that they may finish clinic and go to the local grocery store and they see their patients there, and really ensuring that the resident also feels okay with seeing their patients so frequently out in public. I also want to highlight that this Maine medical track, rural track, splits their hospital medicine time, which I think is really valuable. So they're still getting various hospital rotations at the Portland, Maine site, but also they're doing hospitalist work at the rural site. And I think rural hospital medicine is certainly different than large academic medicine, including some of the following: procedural skills, and there's often not a procedure service at those rural hospitals, getting familiar with diagnostic uncertainties and how to manage these cases when you have limited access to consultants. Also the skill set of triaging and determining when one needs to be transferred to a tertiary care center. And then also figuring out and managing complex discharges when you are in a community that may be under-resourced and a little more challenging to get those patients out of the hospital. So things to consider going forward. Again, I already highlighted the schedule and how I do think it would be important that the rural resident is spending a substantial time in that rural clinic to really gain exposure to rural internal medicine. A few other challenges that I foresee, including number one being funding. Of course, funding is also crucial to getting anything up off the ground. We are fortunate, again, the state programs that I highlighted do offer various grants to help expand rural rotations. Next, finding that right community partner is crucial. So again, finding that right hospital and clinic setup for that rural internal medicine resident. And then finding the local leadership. So finding dedicated, invested attendings, physicians, additional healthcare professionals, and the administrative staff who are interested in having a resident at their site. Also figuring out the logistics of travel and lodging. This also goes into the fact of, again, finding that right rural site. Ideally, you don't want the residents, say, driving 4 hours to their continuity clinic. Also the logistics of where will they stay when they're at their rural site. Developing a new curriculum that's dedicated to individuals pursuing rural internal medicine. Again, the skill set is a little different than, say, if they were pursuing a career in academic medicine. And then, again, I've already highlighted the resident schedule that will be significantly restructured compared to, say, a traditional categorical schedule. And then lastly, recruitment. And I think this will be a big one as far as, I've already highlighted that understandably, the pool of rural general internists is small. And so we want to make sure we are consistent as far as our recruitment goes, and that it would be certainly detrimental if we say we recruited one internal medicine residents to this track, but then we had a lapse in 1 to 2 years where there are no rural IM residents. This would certainly impact particularly that rural community who was relying and depending on that residence to be present. So to wrap things up, I want to highlight what we now know, what we've discussed, and where to go from here. So again, earlier in my talk, I highlighted how the demographics of rural America are changing and will continue to change in future years, and that we're seeing certain racial and ethnic minorities are experiencing population growth in rural communities. And we're also seeing our population age in rural communities as well. We've discussed, unfortunately, that rural health disparities are ongoing and that growing physician shortages likely contribute to this. Expanding rural GME opportunities can be an effective method for recruiting physicians to rural areas. And again, lastly, I want to highlight, as I've touched on many great state and local programs, it is so key that we collaborate with these other departments, programs, and state organizations to help continue to push the effort of expanding rural GME. And I think through collaboration, sharing ideas, sharing resources, I'm hopeful our internal medicine program will be able to offer more rural training experiences for our residents in the future. So to wrap things up, I just want to give a special thanks to many people who have helped me through my career. Specifically for the Grand Rounds Prep, I want to highlight Dr. Jeremy Smith, Dr. Holt, Dr. Schwab, and Lori Rodfeld from WCRGME. Again, they were wonderful resources and helped me prepare this talk. Also from the Department of Medicine, I want to give a huge shout out to Dr. Kelly Lavin, who has been a wonderful support all through residency, through my chief year. I'm so thankful to have her as a mentor. Also Dr. Coyle, Dr. Cheda, Dr. Schnapp, and Dr. Trowbridge, again, have been a wonderful support for me during my training. And then lastly, co-chiefs, again, a huge shout out to Nimrod, Scott, and Lindsay. Also, they were extremely helpful as I was frantically trying to figure out the tech this morning. Again, I am so thankful for having them as my co-chiefs and just experiencing this year together with them. And then I want to give a shout out to my husband, Justin, as well as our lovely dog, Cedar, pictured here, wearing his Wisconsin swag. Again, so thankful for their support. And again, they decided to make the move with me to Wisconsin 4 years ago, and I'm thankful for that. And then lastly, featured below is my future town where I'll be practicing medicine. So that's Anaconda, Montana, pictured below. And again, I'll be practicing general internal medicine at a critical access hospital there. That's all. Thank you.
Thank you, Emily, for a wonderful talk. I do think it is interesting that you chose to share a picture of your dog, but not your husband in your acknowledgements. I'm not sure what that says. And I'm going to hand over the question and answers to Dr. Coyle to moderate.
Great, thanks, Lynn. And thanks, Emily, for a really fantastic talk and an important call to action for all of us, and especially in the residency program. So thank you so much for that. And I think a really important point, and you know, that we can hope that, you know, telehealth and technology will fix, you know, many of the disparities in rural health, but there will always be a role for physicians in the local community and deliberate strategies to ensure that are really important. So I think a lot of questions in the chat. I think kind of one theme for a bunch of the questions so far was sort of like COVID. Everything is sort of COVID. So, you know, the good, COVID in telehealth, the bad, COVID impacting sort of rural communities. So maybe I'll ask you a very general question of sort of like what your perception has been of sort of the impact of COVID in sort of exacerbating or alleviating any sort of health disparities in rural communities.
Yeah, so certainly, I mean, some trends that I found just when reviewing literature. So certainly as of recent, initially when COVID was initially outbreak, we were seeing, of course, higher rates in urban areas, but unfortunately, as time went on, we were seeing a disproportionate amount of individuals in rural areas who were more significantly affected by COVID compared to urban dwellers. So that's one point, again, I just want to highlight in a trend I saw in the literature. As far as, you know, something I noticed, so I think we all experienced, whether it was an urban or rural area, that during COVID, staff outages were frequent, and that really put a stress, you know, for me on clinics specifically. What I did notice when I was interviewing for jobs where I predominantly was interviewing in rural communities, that stress is only felt more when, say, there's already only 2 medical assistants supporting the clinic versus 4. And then when one of those individuals are out in a rural community or a rural clinic, you really feel it all the more. So those were some trends that I saw.
Great, thanks, Emily. I think a really great question from Carrie Gleason. Thanking you for a fantastic talk, and then asking sort of any thoughts on unique challenges on improving disparities for tribal communities, many of which are also in rural areas.
Yeah, you know, I didn't look at specific strategies as far as how to address these, but I will highlight, and I mentioned a few in my talk. Unfortunately, often individuals, American Indians, Alaska Natives are dealing with even greater rural health disparities in those communities. Again, particularly, I touched on the maternal mortality as well as perinatal care in these communities. Unfortunately, it's quite low. And that's, again, another area that I feel like we need to address, and could be a whole other talk.
Mm-hmm. Great. I think a really important question asked, about follow-up data on sort of rural retention of residents in the Wisconsin rural GME programs. Is there any internal data looking at sort of the success of these programs?
Yeah, that is a great question, and I didn't really look into that. And the one study I highlighted for the EM physicians only looked out 2 years, and I think that's a great point. I mean, it's definitely something that comes up is, obviously, sure, we recruit the physician for 1 to 2 years and then we lose them. And so that's certainly not unique, and it definitely happens. Unfortunately, I don't know the data on percentages of how often people are leaving or how long they last until they leave.
Absolutely. And now your co-chief's throwing you some questions as well. So Nimrod has a challenging question for you, which is sort of like, when do you think is the moment that is sort of optimal for exposure for rural health? For someone who may not be coming into medical training, thinking about, a career in rural health, do you think it's more important to sort of build exposures in medical school and residency, both? Like when do you see as sort of the optimal moment to sort of do this kind of training?
Yeah, that's a great point. I mean, I think it's important. Ideally, in the perfect world, you'd kind of scatter it, because as you can imagine, in med school, you have a different perspective on just how a clinic operates, and you're thinking about different things, versus as a resident, you have a different take on medicine. So ideally, it'd be nice if we're able to sprinkle, say some rural opportunities as a medical student, and then also as a resident.
That's great. And then a great question from Tasha. So what might be the opportunities for internal medicine to collaborate with family medicine, who has many rural clinics and training opportunities for family medicine?
Yeah, I think there is definitely a collaboration that should be had. I mean, certainly I talked with Dr. Schwab, who's in family medicine, and, it's just wonderful to see, there are so many family medicine opportunities out there, and they already have established connections with communities. And so I think certainly working with family medicine, to even say establish a site with that community where there's maybe already family medicine residents there could be a good opportunity.
Yeah, I think a couple interesting comments in the chat and in the questions about, I think highlighting something you already highlighted, Emily, which is the importance of having continuity within the track, that if you have sort of gaps, then you're sort of leaving sort of shortfalls, and the importance of sort of building faculty. I think often the chicken and the egg situation where like you need faculty, but you need also trained residents in rural health to get faculty in the local environment.
Yeah.
There was sort of one last question, we'll end with that, was, asking if there are sort of any sort of, out of match spots directly for medical students. And I guess the broader question is, how have you seen in the literature, places trying to navigate that transition from like a rural track in medical school to a rural track in residency? Are there better ways to link that connection that you've seen or have thought about?
Yeah, that's a great question. I haven't seen many where there's kind of a link of, say, if you're in a rural med school track, then you're kind of teed up to then enter a like rural residency track. I don't have that, but certainly, I mean, I think it kind of naturally works that then that rural medical student kind of seeks out those residencies that maybe say are in a rural area or have some, passions or interests in rural medicine, but I haven't seen a clear link.
Great. Thanks, Emily. So we're right at 9. So I want to thank Emily again for a really sort of fantastic talk, highlighting a really important health disparity here in Wisconsin. And like I said, I think an important call to action for all of us to think about how we build that rural healthcare workforce for Wisconsin.
Awesome. Thank you so much.
Great.
Thank you. Awesome job again.
All right. Thank you. Bye.